Hi, my name is Mitchell Brown, and today we will look at the Unit 4 case connections. I decided first to look at case 1, and to first present this case, a newborn girl appeared normal at birth, but within 24 hours she developed lethargia, hypothermia, and apnea. So the attending physician suspected that there was a metabolic disorder and ordered a panel of labs to be run on this patient. So the question is posed after this: which diagnosis would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? So we will discuss these different panels now. So first, a blood glucose test. So I decided that neither of these processes deal with glucose or have an effect on blood glucose levels. So this would not be a good test to determine or distinguish between the two. Second test of urinary acids. In the urea cycle disorders, we will see elevated levels of citrulline, arginine, and ammonia. We can also see increased levels of uric acid. So using a urinary acid test, we can detect these 4 different acids that would then be present in the urine. So the urinary acid test is great at detecting disorders in the urea cycle. So the third test is a serum fatty acid test. So deficiencies in beta oxidation will increase the amounts of free fatty acid in the blood. This is if we are unable to transport free fatty acids into the mitochondria using our transport enzyme palmitoyltransferase 1. So this serum fatty acids test would be a great indicator of whether we have deficiencies in beta oxidation. The fourth test, plasma glutamine, would not be a good test to determine between these two, again because neither of these processes deal with glutamine and would not affect plasma levels of glutamine. So the 2 tests that I determined would be best is a urinary acid test and a serum fatty acid test. So all of the blood work was then run on this patient, and these were the results. So we had high ammonia levels in the blood, which again points to a urea acid or a urea cycle deficiency. And again, they rose rapidly. The urine uric acid levels were also markedly elevated, which will also point to a deficiency in the urea cycle. The plasma citrulline levels were normal, and the final question posed after this was, in this patient where uric acid levels are elevated, list 1 urea cycle enzyme that is most likely deficient and 1 urea cycle enzyme that is least likely to be impaired. So I looked into this, and the 2 enzymes that I found were carbamyl phosphate synthetase 1 and ornithine carbamyl transferase. So looking at these 2 enzymes, and also this that is presented, if uric acid levels are elevated, this suggests an elevated level of carbamyl phosphate. This would imply that our carbamyl phosphate synthetase 1 is active and not impaired, so that answers the second part of our question. So these high levels would also indicate that ornithine carbamyl transferase is deficient and is not converting carbamyl phosphate to citrulline. So this answers the first part of our question of our deficient enzyme. So these high levels of carbamyl phosphate would be used in pyrimidine synthesis and converted to uric acid, thus contributing to the high levels of uric acid that we see. So that is it for case 1. The next case that I decided to look at was case 3. So to present case 3, a 47-year-old man presents with severe pain in his great toe. He is unable to bear weight on his right foot, and there was no apparent trauma to his foot. He reports the pain started last night and continued to increase in severity. Based on his physician's exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis was performed. So the results are shown here. And in this patient, we see that there are very elevated levels of plasma urate that are circulating in the body. A normal level is less than 7, where our patient is at 10.5. We also see that our urinary uric acid is very low at a decreased level. So the question posed after looking at these labs is, what is the best explanation for the presentation of gout in this individual? And please explain why the other choices are not consistent with the data, or what additional information you need to decide the root cause. So first, the overproduction of purines. This could be possible, but we don't have enough information to determine if this was the exact cause. But when we have low urinary output of uric acid, we suspect that it would more likely point to a decreased excretion. So we'll say it's not number 1. Number 2 is a decreased salvage of purines. Again, it could be a decreased salvage because we show increased plasma urate, but we again do not have enough information to determine this. And again, the low urinary excretion points to the decreased excretion of uric acid. So looking at that third case, decreased urinary excretion of our uric acid, this is definitely what our data points most towards. This is likely the cause because there is an increased level of uric acid in the blood, and this is shown with the blood test and with a very high plasma urate. But the main indicator and the information that points us to this decreased excretion is would be the low uric acid levels in the urine in the urinalysis test. So after further discussing with the patient, he tells you that he recently switched from diet soda to regular soda because he read that fake sugar diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda a day. So we know that this non-diet soda, the primary sugar is fructose or high fructose corn syrup. So the question is posed, what is the potential impact of this dietary modification on the presentation of gout? So as I researched into this a little bit, found that looking back at previous chapters, fructose, when metabolized, will result in uric acid. As we have increased uric acid levels, again, as presented in our labs above, this can lead to gout. Upon further study, I found a study that was performed by some Harvard students. And in this study, they showed that the increase in uric acid from the metabolism of fructose is generally due to the kidney's inability to keep up with the high levels of uric acid from the conversion of or metabolism of fructose. The study also suggests that it could also be due to an overproduction of uric acid from the metabolism of fructose. So after discussing this with the patient, we know that this dietary modification could definitely have led to his presentation of gout. Well, that is it for case 3 and for our unit 4 case connections. Thank you for watching.